Good morning, respected senators and professors and colleagues. My name is Keimyung from the first affiliated hospital of Seoul University, China. Today, I will present my early clinical experience of lower robotic traction system for ESD. Part of this work had been published in the e-video section for endoscopy. I have no personal or financial interest to declare. Endoscopic and submucosal dissection, or ESD, is an established technique for unblocked resection of superficial gastrointestinal lesions. However, it remains technically demanding. The key challenge is not just cutting, but achieving stable or sustainable exposure of submucosal plane. In many cases, especially in the early stage of dissection, or in gravity-dependent locations, we face the limited countertraction, poor visualization, and increased risk of bleeding or perforation. So fundamentally, the bottleneck of ESD is traction. Several traction methods had been developed, such as clip with line, polar systems, and magnetic traction. However, these approaches had important limitations. Most of them provide stable traction and a fixed direction or limited adjustability. They are also not well integrated into the standard workflow. As a result, their clinical utilization were limited. So, to address this issue, we applied a lower system called Faster. This is a flexible and nominal robotic traction system, which was composed of an actuator-driven mechanism, a master controller, and an electronic control system. It's a compact robotic arm system that mounts externally to stand endoscopist. As shown on the right, the robotic arm provides multi-directional articulation. The system is operated using a joystick, allowing pierce grasping, repeated re-grasping, and multi-directional traction. The video should demonstrate the system setup and the integration into the procedure. Device setup takes approximately 3 minutes and can be smoothly incorporated into the routine endoscopic workflow. Here we can see the Dr. Lee performing esophageal ESD, where the assistant controls the master controller to poison the grasping on the target lesion. Here we present a case of gastro lesion in the ultra-magnified NBI revealed an irregular partner, and ESD is indicated. After initial preparation, the traction system was applied. The mucosal flap was lifted, resulting in clear exposure of the submucosal layer and a stable visual field. Dissection could then be performed in a more controlled manner, and unblocked resection was successfully achieved. And this is also where the system makes the real difference. Our early cohort include 8 consecutive patients, including lesions in esophagus, stomach, and colon. The result is encouraged. We achieved 100% unblocked resection and other resection where applicable. Most importantly, we maintained stable traction even in challenged location with 0 intraoperative perforation. One case of delayed bleeding, mainly via endoscopy intervention. Our early experience suggests that this system is feasible, safe, and may improve procedural efficiency. And I'd like to highlight one case of gastrogist. In this case, robotic traction enables inward mobilization of the tumor, which clearly exposed the interface between the tumor and submucosal propria. It allowed controlled dissection within or along muscle layer without the need of internal for cyclic resection. So importantly, The robotic traction does not just improve the visualization, and it actually changed the dissection strategy. We can see in the video the resection was smoothly and the exposure was clear. And our clinic findings are consistent with poor clinic data published in gastrointestinal endoscope and digestive endoscope show that this system can reduce procedure time, enhance some mucosal visualization, and minimize muscular injury. Importantly, for low-voice operators, ignore technical difficulty, reduce advice, and alienate procedure fatigue. So together, these results support that the clinic potential of this system. And so in conclusion, this is a small sample or single-center clinic experience and or procedure were performed by an experienced endoscopist. The lack of cooperative control group preclude defective conclusion regarding its superiority over conventional techniques. Nevertheless, the preliminary results demonstrate that the feasibility and safety of this approach. In the future, large-scale prospective and comparative studies will warrant to further evaluate. We have to admit that it simplifies the ESD procedure and the potential to significantly shorten the learning curve for the next generation of endoscopists. Thank you for your attention.
Thank you, Chairman. My name is Jeong, and the topic is about lower postoperative complications in robotic gastrectomy with the surgical navigation system. I have no COI to disclose. However, Professor Woo Jin-hyung, the correspondent of this study, is the CEO of Hyeong, which provides the RUS surgical navigation system. Radical gastrectomy involves ligation or preservation of major vessels and lymphadenectomy along these vessels. To optimize oncologic safety, precise lymph node dissection along the major vessel is essential. Therefore, the vascular anatomy is fundamental in gastric cancer surgery. However, in the actual operative field, these major vessels are not often clearly visualized before dissection, which may increase the risk of injury. In our previous study, we digitized vascular anatomy patterns, and here the left gastric artery is shown as an example. We then integrated the patterns of 23 gastrectomy-related vessels and digitally encoded each patient's vascular configuration into a digital number. This revealed that the gastrectomy-related vascular anatomy is far more complex and heterogeneous than we had expected. These findings emphasize the importance of patient-specific anatomical understanding and individualized assessment in gastrectomy. The next question is then whether the translating patient-specific vascular information into the operative field can improve the surgical outcomes. Therefore, this study aimed to evaluate whether the use of surgical navigation system is associated with surgical outcomes after robotic gastrectomy. At our institution, the routine preoperative evaluation includes CT angiography with 1 mm slice. In patients undergoing surgery with the navigation system, patient-specific 3D vascular anatomy is reconstructed from these images. The navigation system supported the preoperative planning, including the vascular assessment and the port replacement simulation. It also provided the intraoperative anatomical guidance through the robotic console display. We included 1,252 patients who underwent robotic gastrectomy between January 2021 and October 2025. The navigation and non-navigation group were compared after propensity score matching using the 12 pre-specified variables. The study outcomes included pathological findings, the post-operative course, and laboratory findings and post-operative complications. Post-operative complications were defined as events occurring within the within the first 30 post-operative days, including those identified during the readmission. The complications were further classified as local and systemic complications. Among the local complications, the pancreas-related complication included peripancreatic abscess, the pancreatitis, and postoperative pancreatic fistula, the POPF. And the POPF was defined according to the 2016 ISGPS definitions. These are the results. In the clinical and surgical characteristic, and before the matching, there were significant difference between the groups in sex, BMI, the operator, the tumor location, and the reconstruction method. But after the propensity score matching, 473 patients were each included in each group, and as shown in the log plot, all matching variables were well balanced with the standardized mean difference below 0.1. Regarding the pathologic outcomes, there were some differences in pathological findings between such as Lowland classification, the perineural invasion, and the T stage. However, the main focus of this study was the short-term post-operative morbidity rather than the oncologic adequacy. The navigation group also showed a higher lymph node retrieval in the navigation group. In the post-operative course and laboratory findings, the intraoperative drain insertion was less frequent in the navigation group, and the first flatus occurred slightly earlier. And otherwise, the other post-operative course was generally comparable between the groups, with no significant difference in the hemoglobin or inflammation marker. The serum amylase level was slightly higher in the navigation group, but both group had remained within the normal range. The drain amylase and lipase levels tended to be lower in the navigation group, although these differences were not statistically significant except the postoperative day 1 lipase level. In the postoperative complications, the rate of grade 2 or higher complications were significantly lower in the navigation group, and in particular, the local complication, especially the pancreas-related complications, were significantly less frequent in the navigation group. And there were no significant difference between the major complication or the systemic complications. In the multivariable analysis, the use of surgical navigation system along with the sex and age remained independently associated with the postoperative complications. The lower complication rate observed in the navigation group may be explained as follows. The use of surgical navigation system likely improved the patient-specific anatomical orientation, which may have facilitated more precise lymph node dissection with the less inadvertent injury to the surrounding tissue. This interpretation is also supported by the trend toward lower drain amylase and lipase level in the navigation group. So consequently, these findings suggest that improved anatomical guidance may have contributed to lower procedure-related local complications such as pancreatitis, pancreas-related complications. So in conclusion, the use of surgical navigation system was associated with significantly lower postoperative complication rate, particularly with the pancreas-related complications. These findings suggest that enhanced patient-specific anatomical guidance may help reduce the procedure-related morbidity during lymphadenectomy. Thank you.
Okay. Yeah. Thank you for your introduction, and good morning, ladies and gentlemen. My name is Jin from Ayin Hospital, Incheon, South Korea. My presentation is about my clinical experience of the 500 cases of single-port robotic areola approach thyroid surgery. Thyroid cancer, as you know, the most frequently occurred cancer not only in the Korea but also in worldwide, and it is thyroid gland, because the thyroid gland is located anterior portion of the neck, so the scar is always matter after the surgery. And most patients are very young, around 30 or 40 or 50, and they are very socially active and mostly occur in the woman. But the prognosis is really excellent compared to the other solid organ cancer. So the cosmetic outcome really matters for the young woman patient. And the visible neck scar remains a major post-operative concern in the most of the thyroid cancer patients. So for this reason, around 20 years ago, the many types of the robotic surgery to not leave the scar in the neck has been developed from the multiport. It as a representative method was a transaxillary or BABA and a little bit on retroauricular, and recently the transoral approach. But this kind of multiple system requires high demand for the wide working space before the robotic docking. So, and the other concern, the transaxillary surgery is a limited contralateral thyroid gland access, and also often need the retractor or the field surgeon who are very skillful to push down the trachea. And in the BABA approach is provide excellent bilateral surgical view, but it requires most wider flap, broader flap dissection compared to the other method. And transoral surgery is a very scarless method, but it's limited to the lateral leg node dissection, and it's only it has a unique approach-related complications such as oral cavity infection and such as mental nerve injuries. So it's kind of weird situation after the surgery. And in the year of 2022, the single port system, Da Vinci SP system, has been launched, and in the 2025, the state of Da Vinci surgery in Korea has been shifted into the SP system-based surgery. So the transaxillary multipolar system has evolved to the START and COSTA, and BABA surgery has evolved to Supra, and this method is the method that I developed, and the transoral also moved to the SP transoral method, and other methods are shifting to the single port-based method in these days. The Supra I will introduce about briefly, and in single port robotic areolar approach I developed in the 2022, and I started my first case in the Christmas Eve at the time, and it's originally developed from the BABA. I have around 10,000 experience about the BABA approach before, and it evolved from the BABA to the single port method. It also provides upside down view, and it's easy access to the both thyroid gland with easily, and lateral lymph node dissection is possible, and don't need to change the robotic docking. Only it makes the right areolar side robotic docking during the whole surgery, and the flap area is very smaller compared to the other method. Only we need to the entry of the robotic arm and access directly to the thyroid space, and it's really minimally invasive compared to the other robotic surgical method. And no separate equipment such as axillary retractor is not necessary. Only I use the robotic system and the CO2 gas, and don't need to any assistant without me and robot. And there's no risk of unusual complications such as infection or something. And this is the flap design. I always use the right areola because right areola is very accustomed to the BABA surgeon, and it upside down view. This is neck dissection view, and after surgery there is no visible scar at all. And you see the right thyroidectomy view, and this is the left thyroidectomy view. It provides the both same vision under the upside down view. And next, SPRA can also be applied to the MRND neck dissection in the advanced cases. And this is the right level 4 vision and right level 3. And we can go up to the right level 2B and 2A without any complications or changing the robotic. And also we can do the redo surgery for the recurrent lymph node cancer or recurrent surgery. This is a view of the recurrent metastatic lymph node after first initial neck dissection, and she has a recurrence in the level 2. And I do the respiratory method again, and I found that this lymph node and cut the lymph node dissection and for the reduced surgery. And also it is very suitable for the obesity patient. Highest BMI for my experience of 42 kilograms per meter, and it's comfortable compared to even the open surgery, because the open surgery we should meet the thick depth of the subcutaneous fat, but with this method only we can see the thyroid gland without the fat. And also it can be safely applied to breast augmentation patient. When the breast augmentation layer go under the pectoralis muscle, and this Supra method only goes to the subcutaneous tissue, so it's not kind of the obstacle. Also, it can apply to the male patient. It looks like 3 centimeters very long, but for the man, it is always possible when we do make a periareolar incision properly. And the flap was started initially from the bilateral breast, but it moved to the left axilla and right axilla for the assist port. And the flap, in these days, I use this method to minimize the flap. And also, it can apply the parasitectomy. And this is a summary of 500 cases of mine, and for age of 43, and the male patient also 26 included, and highest BMI was 42, and many types of the surgery can be done. And along the lobectomy, total thyroidectomy, and completion and MRND, the flap time before the docking is around 10 minutes, and consult time is around 42, and the 69 in the total thyroidectomy. And also, even when I do the neck dissection, only takes 160 minutes. And post-operatively, vocal cord palsy rate less than 1%, and hypoparathyroidism was very low, and the calcium and phosphorus is suitable. And pathologic diagnosis was almost papillary cell cancer, and the lymph node status, we can get the lymph node around more than 30 lymph nodes in the MRND cases. And after the surgery, the thyroglobulin level showed 90% was below the zero. It means that there is very oncologically safe method compared to the other method. In summary, surprise a highly minimally invasive robotic dialysis technique in these days and provide effective access and excellent safety and satisfactory oncological surgical completeness. And also, it can apply thyroidectomy and neck dissection and other reduced surgery. And what is further multi-center training and the compared study are required to support my result. In summary, this message represents the next step platform, the minimal invasive endocrine surgery. Thank you very much.
Good morning, I'm Min-Hyung from Ewha Women's University Seoul Hospital. Today's topic is surgical and oncologic outcomes of single-port robotic surgery compared to conventional laparoscopic colectomy for colon cancer. I have no disclosure. Single-port laparoscopic surgery was first introduced in colorectal surgery in 2008. And since then, numerous comparative studies have been conducted, and most of have shown no significant differences in postoperative outcomes between single-port and multi-port surgery. In addition, single-port laparoscopic surgery presents several technical challenges, including difficulty in achieving surgical triangle, frequent instrument collisions, and increased ergonomic strain. With this background, DaVinci SP platform was introduced in 2018. DaVinci SP deploys a flexible 3D camera and three fully wristed, independently articulating robotic instruments. This features combines the advantages of single-port access with robotic system and may expand the applicability of single-port surgery. To date, many studies have reported the safety and technical feasibility of SP robot surgery. However, most of these are case series. Only a few comparative studies have been published evaluating SP surgery compared to multi-port laparoscopic, multi-port robotic, or single-port laparoscopic surgery. So we aim to evaluate the surgical and oncologic outcomes of single-port robotic surgery compared to conventional multi-port laparoscopic surgery in patients with colon cancer. Our group previously published a study comparing short-term outcomes between these two approaches. In the present study, we expanded that cohort with a larger sample size and additionally evaluate oncologic outcomes. Our study was a retrospective cohort study in a single center, including a patient who underwent surgery for colon cancer between, 2019 and 2025. To adjust for baseline difference between the two groups, we applied propensity score overlap weighting, or PSOW, a statistical method that emphasized patients in overlap covariate region, and thereby improving the balance and reducing selection bias. As shown in this flowchart, a total of 472 patients were included in the final analysis, 313 in the conventional laparoscopic group and 142 in the single-port robotic group. In baseline characteristics, the two groups were initially imbalanced. The robotic group was significantly younger and more female patient and better ASA scores. However, after applying PSOW, all baseline variables were well balanced between the two groups. Regarding intraoperative outcomes, the operation time was shorter in the laparoscopic group. and there were no cases of intraoperative transfusion or open conversion in the SP robotic group. In postoperative outcomes, the complication rates were comparable, and however, the SP robotic group showed faster recovery, such as in first flatus, initiation of a soft diet, hospital stays, and reduced interval to the start adjuvant chemotherapy. The rate of opiate withdrawal were significantly higher in the SP robotic group. The maximal postoperative CRP level was lower in the SP robotic group. For pathologic outcomes, tumor stage distribution was comparable between the two groups. Other pathologic variables, including histology, vascular invasion, the number of positive lymph nodes, and the resection margin, were comparable between the groups. But the SP robotic group showed a tendency toward more lymphatic invasion and higher lymph node harvest, although these differences reached only marginal significance. In the postoperative pain score analysis, SP robotic group showed consistently and significantly lower pain scores at all assessed time point. Regarding oncologic outcomes, a relapse-free survivor showed no significant difference between the two groups with a mean follow-up of 31 months. In Cox regression analysis, the surgical approach was not an independent predictor of relapse-free survivor. Histology grade was the independent prognostic factor. Similarly, overall survival was also comparable. Again, the surgical approach was not an independent predictor of overall survival in multivariate analysis. Tumor stage and perineal invasion were the independent prognostic factors. We also analyzed local recurrence. Local recurrence occurred in 4 cases in laparoscopic group and 1 case in robot group, and there were no significant association between surgical approach and local recurrence. But for these outcomes, interpretation is limited by the small number of events, only 5 events. In this study, single-port robotic surgery demonstrated comparable surgical and oncologic outcomes to conventional multi-port laparoscopic surgery, with faster post-operative recovery and significantly reduced pain, but there remains some limitation in the SP platform, such as the lack of advanced energy device. Regarding the stapler, it was previously unavailable but has recently been released. We expect that further technological advancement will continue to expand the applicability of this platform. Thank you for your attention.
Good morning, everyone. I am Yeonsu Kim from Gangnam Severance Hospital. I will start my presentation. I have no COI. Liver surgery is technically challenging because of the complex anatomy, anatomical variations, and risk of bleeding. Because of this, minimally invasive surgery was adopted more slowly in liver surgery than in other abdominal surgeries. However, as surgical instruments and 3D imaging technology have improved, minimally invasive liver surgery has become more common. Robotic surgery has emerged as another option in addition to conventional laparoscopic surgery. More recently, single-site robotic systems have also been introduced. This study was published in the International Journal of Medical Robotics and Computer-Assisted Surgery in 2023. It reported the early experience with single-site plus one-port surgery using the Da Vinci Xi system. The authors reported donor hepatectomy, pancreatic duodenectomy, segmental resection of the common bile duct, and spleen-preserving distal pancreatectomy using the Xi single plus one approach. This study demonstrated the feasibility of single-site plus one robotic surgery in the field of HVP surgery. This study was published in Surgical Endoscopy in 2025. It reported hepatectomy using the Da Vinci SP system. Actually, these were single-site plus one cases. The study includes 14 hepatectomy cases performed with the SP system between April 2024 and May 2025, including 5 major hepatectomies. The authors showed that liver resection using the SP robotic system is technically feasible and safe. So based on these findings, we aim to compare laparoscopic multiple donor hepatectomy and robotic single plus one or single port donor hepatectomy. The single plus one approach was performed using the Da Vinci Xi system, and single-port donor hepatectomy was performed using the Da Vinci SP system. We also performed a subgroup analysis comparing these two robotic approaches. This was a retrospective single-center study of patients who underwent right living donor hepatectomy between 2018 and 2025. Patients who underwent left hepatectomy or open hepatectomy were excluded. A total of 76 patients were enrolled, including 60 patients in the laparoscopic group and 16 patients in the robotic group. Among these robotic cases, 11 were in the XI group and 5 were in the SP group. Donor evaluation was performed through the standard evaluation process. First, in the laparoscopic group, the total of the 4 trocars were used. 2 12mm trocars and 2 5mm trocars were inserted and used. Graft retrieval was performed through the Van-Steer incision. For the XI system, a glove port was placed through the transumbilical incision for the camera and 2 robotic arms. 1 additional robotic arm was inserted in the right mid-abdomen area. The right mid-abdomen port site was later used as a drain insertion site. If assistance was needed during the robotic operation, the glove port was used. Vessel division was performed after conversion to single-port laparoscopy. For the Da Vinci SP system, the camera and 3 robotic arms were inserted through the transumbilical incision. The assist port was inserted through the Van-Steer incision and no drain was placed. Also, vessel division was performed after conversion to single-port laparoscopy. Now, I will present the baseline characteristics of the study population. A total of 76 patients were enrolled, with the mean age was 35.5 years. The mean warm ischemic time was 9.4 minutes. There were 7 patients with a major complication, including 4 patients with biliary complication. We compared the laparoscopic group and the robotic group. There were no significant differences between the 2 groups except for the warm ischemic time. The mean warm ischemic time was 8.7 minutes in the laparoscopic group and 12.1 minutes in the robotic group, showing a longer warm ischemic time in the robotic group. All major complications and biliary complications occurred in the laparoscopic group. We also performed a subgroup analysis comparing the XI group and the SP group. There are no significant differences between the 2 groups in the graft-out time, warm ischemic time, or other perioperative outcomes. However, the SP group showed a trend toward a shorter hospital stay. In conclusion, single-site +1 or single-port robotic donor hepatectomy showed comparable perioperative outcomes to laparoscopic donor hepatectomy. The longer warm ischemic time in the robotic cases may be related to vascular division followed by conversion to single-port laparoscopy approach. It may require an additional learning curve and could improve with further experience. When you compare the XI system and the SP system, the differences was not statistically significant, but the SP system showed a trend toward a shorter hospital stay. As I mentioned earlier, the main differences between the 2 systems is the additional trocar insertion in the right mid-abdomen area and the use of the drain. Because of patients in the SP group did not require the additional incision or drain placement, they may have experienced faster recovery of general condition and less pain, which may have allowed earlier discharge. Based on these findings, single-site +1 port hepatectomy using the Da Vinci XI system and single-port hepatectomy using the Da Vinci SP system may be feasible and safe option in the selective donors. And finally, this study is meaningful because it is one of the first report of the donor hepatectomy using the Da Vinci SP system. This study has several limitations, including its retrospective single-center design and small sample size. In the future, we plan to include a larger number of patients for the further evaluation. We also plan to investigate post-operative pain, analgesic use, which was not evaluated in the current study. Thank you.
Thank you for your kind introduction. There's no COI. The number of robotic PD is on the rise, and our center, as well as the proportion of robotic PD among all PDs, has been steadily increasing. Last year, more than half of all PD were robotic in our center. Although there are existing scoring systems for predicting post-operative outcomes related to robot PD, their number is limited. And while the learning curve plays a significant role in the occurrence of complications, there is currently a lack of scoring systems that including learning curve. Meanwhile, the ISGPS, the International Study Group of Pancreatic Surgery, released a grading system for MIPD, which evaluates the safety of the procedure by introducing an experience grade determined by the anatomical complexity factor and center volume and surgeon experience. Then, the aim of this study is to validate actual efficacy of this grading system in robot PD and identify clinical risk factors that predict the difficulty of robot PD. Patients who underwent robot PD in SNUH from 2016 to 2025 were retrospectively reviewed, and total 918 patients were analyzed. First, experience grading was based on the center volume and surgeon's experience. According to QSUM learning curve analysis, the data follows a typical learning curve, peaking at around 100 in operative time and then showing a steady decline. The cutoff points of 40 and 80 used in the existing grading system can be considered quite reasonable. Next, we compared individual grade characteristics that showing differences in age, BMI, OP history, and proportion of diagnosed disease. However, there were no difference in distribution of complexity grades in robot PD. In perioperative outcome, there was a clear trend showing that operating time and blood loss decreased progressively with experience level. Also, it maintained the overall trend even in the case of major complication, open conversion, and CRPOPF, and demonstrates significant strengths in grade C surgeons. According to this, we can say experience grade in ISGPS grading is a useful predictor of post-operative outcomes. Next, complexity grade is composed of duct sizes, vascular contact, obesity, and open history, histories. Then the scoring system determines which grade is the patient. Among complexity grade, several factors show difference, including age, diagnosis, and neoadjuvant therapy, but it did not follow in consistent direction along the grades. Also, except grading factors, even preoperative biliary drainage showed opposed direction of distribution, lowest in grade C. In perioperative outcome, complexity grade failed to show significant differences between grades in operation time and blood loss. Also, complication and open conversion failed to show significant difference between grades. Then we can see complexity grade of ISGPS grading system showed limited predictive ability for post-operative outcomes. Last, the combined grade system with the experience level and complexity grade defines a group that allows for safe surgery depending on the combinations, and in this study, all other cases were classified as unsafe group. Between the safe group and unsafe group, the safe group it definitely showed better result than the unsafe group in terms of operation time and blood loss. Also better result in major complication, open conversion, and CRPOPF in safe group. However, this ISGPS model's discriminative ability for predicting complication or open conversion was low, with AUC of just 0.53 to 0.57. This highlights the shortcomings of the current grading system. Then next, logistic regression for major complications showed independent factors of sex, ASA, and CVD cancer, and experience grade as independent factors, but also the complexity grade was not remained statistically insignificant, so highlighting the limitation of the previous grading system. Then, given the limited discriminative ability of the current grading system, we tried to develop a more accurate predictive model using machine learning. We introduced brief. We compared 5 machine learning models for model selection, and internal validation was done. According to logistic regression, odd ratio, and AUC value, candidate variables were selected, including those 7 factors: operator grade, sex, and p-duct size, diagnosis of CVD cancer, preoperative biliary range, and BMI, ASA grade. After development of algorithm, the logistic regression model was selected as showing stable performance and better calibration with higher AUC. And in internal validation, the optimism corrected AUC was 0.637, indicating relatively stable performance with minimal overfitting, showing stability of model and showing better AUC level value than ISGPS grading system, which was AUC of 0.5. According to this model, we observed that as the risk increased, there was a corresponding trend toward a higher rate of major complication, open conversion, and CRPOPF, which means we should enhance the previous grading system, which can accurately predict the major complications. In summary, experience grade was dominant determinant of perioperative outcomes in lower PD, whereas complexity grade alone showed no significant association with postoperative complications. The combined ISGPS MIPD grading system demonstrated consistent outcome differences, yet showed limited discriminative ability for predicting individual complications. On multivariate analysis, patient sex, ASA score, tumor type, CVD cancer with the worst outcome, and experience grade were independent predictor of major complications. Then new proposed model integrating operator learning curve and anatomic patient characteristics showed stable function. In conclusion, surgical complexity in lower PD should not be defined solely by anatomical factors, but must incorporate surgeon's experience and patient-specific risk factors. Thank you for your kind attention.
Thank you for kind introduction. Today, I will share our early experience using the Da Vinci single-port system in pediatric abdominal surgery across 2 centers. I have no disclosure. So minimally invasive surgery is now standard in pediatric surgery. However, laparoscopic has limitations in small operative spaces. Robotic surgery improves DEX, but usually requires multiple incisions. So this creates interest in a single-port robotic approach in pediatric patients. This slide shows the evolution of the surgery. After open surgery, laparoscopic becomes common in the 1990s. And the robotic surgery in adults followed in, and the pediatric robotic surgery was introduced since 2001. Despite this progress, pediatric applications remains technically challenging. The SP system allows surgery through a single 2.5 centimeters incision. This may improve cosmetic outcomes and reduce abdominal wall trauma. However, SP surgery is still rarely used in children, and feasibility remains unclear. SP surgery is difficult in children because of the small abdominal cavity. Working distance is limited, and the instrument collision can occur. Therefore, the standard adult SP approach cannot be directly applied in children. So if you see this picture, then at least 13.7 centimeters is needed from the port side to the target. But this size is not possible to the pediatric patient. So to overcome this limitation, we used an access-port technique. This creates a floating cannula system and artificial working distance. It improves the triangulation and reduces instrument collision. So in our experience, this technique is essential in pediatric SP surgery system. This study is a retrospective study from 2 centers. Between August 2023 and September 2025, we included 21 pediatric patients who underwent SP robotic surgery, and we reviewed demographics and the perioperative outcomes. This patient was a 14-month-old girl with 10 kilogram with a Todani type 4A choledochal cyst. In this case, in the right side, during the cyst dissection, SP system provides a superior operative view and more comfortable dissection compared with a conventional 5mm laparoscopic camera. In addition, in the right side, in patients with a protein plug within the common channel, as you see in this case, a small opening can be made easily in the common bile duct to allow free bugination. So after bugination, a disappearance of a protein plug can be confirmed by intraoperative cholangiography. So this case highlights the feasibility of techniques in complex hepatobiliary surgery. This is another representative case. The patient was a 12-month-old male weighing 11 kilograms with a total colonic Hirschsprung disease after previous ileostomy. We performed a total proctocolectomy with a Swanson pull-through using the SP platform. This case demonstrates one of the major advantages of the SP system, the ability to perform dissection from multiple directions without the needs of additional ports. By simply rotating the SP platform itself, the surgeon can approach with the operative field from the left, right, superior, and inferior direction. So in this patient, this flexibility was particularly helpful during the procedure. This demonstrates that SP surgery can also be applied to advanced colorectal reconstruction in pediatric patients as well. This table summarizes patients on demographics and procedure distribution. The study included 21 patients with a median age of 4-year-old, and a median body weight is 18 kilograms. But the priority, the least age is 3 months, 2 or 3 months, and the body weight is the least is 5 kilograms. The procedure included choledochal cystic excision and cholecystectomy, Kasai portoenterostomy, and splenectomy, and hiatal hernia repair. More than half of these cases were completed using a simple incision alone, and this suggests broad application across the different pediatric abdominal procedures. The median OP time was 315 minutes, and estimated blood loss was very minimal, and only one patient required interoperative transfusion and open conversion. The overall complication rate was 28.6, which is minimal, with major complications occurs in 2 patients. Median time to oral intake was 2 days, and hospital stay was 6 days. Overall, these outcomes suggest acceptable and early perioperative results. So this is the detailed individual patient outcomes. We included the patient across the broad range of age, body weight, and surgical indication. Importantly, even very small infants and technically demanding procedures could be managed using the SP platform. These detailed results support the feasibility of SP surgery in carefully selected pediatric patients. So in conclusion, SP robotic surgery appears feasible even in infants. The access port technique is crucial for overcoming anatomical limitations in pediatric patients. This approach may provide cosmetic benefits while maintaining acceptable surgical outcomes. However, larger multi-center comparative studies are still needed to validate long-term safety and effectiveness. So thank you for your attention.